Hello and welcome to our lesson about antivirals that target the HIV virus. Here's the outline. HIV is probably the most high-yield virus you're going to learn about in your medical school career. So you need to know every single aspect of the HIV's life cycle when it is infecting the T lymphocyte. We're also going to talk about, in this lesson, about the antibiotics that we use to treat HIV infections and prevent them from replicating. And we're also going to talk about more clinical treatments, like more clinical treatments of what you would expect to use in a hospital or a clinical setting for HIV patients. It's one of the few viruses where you're expected to know the whole regimen. Let's talk about the HIV life cycle. HIV has three major genes that you need to know about. The first gene is going to be the ENV gene, or the envelope gene, and it does exactly what you think. It makes the envelope. It is consistent of a GP160, which is cleaved into two different segments, a 120 and a 41. So first of all, this GP120 is going to be the part of the protein that initially binds into the receptor CCR5, which is found on the macrophages. So in the initial infection, it binds onto the CCR5 of macrophages. In the later chronic disease infection, it's going to bind onto the CD4 of the T lymphocytes. So it starts off binding on to the macrophages, then it eventually leads on and starts infecting the T lymphocytes. We're going to talk about Maraviroc, which inhibits the binding onto the CCR5. The next protein that's also in the envelope is going to be the GP41, which is the fusion protein. It encourages the fusion between the membrane of the HIV virus and our membrane, and we can use drugs like enfuviratide, which can inhibit this fusion. The next gene we need to talk about is going to be the POL, or the polymerizing gene, and this is important for the replication of the virus. It has three different enzymes that you need to know. The first one being a reverse transcriptase, or RT. This reverse transcriptase turns the HIV's RNA into DNA, and what we can do is we can use NRTIs or NNRTIs to inhibit this DNA formation. Another thing you need to know is an aspartate protease. Most people just say protease. And this protease is going to cleave the polyprotein that is being made by the HIV virus. And if we're going to inhibit it just by this class of drugs called protease inhibitors. We're going to then talk about the integrase. Integrase is how the virus integrates its newly formed DNA into our chromosome, and that's how it can stay latent for long periods of time until you eventually just develop full-blown AIDS. And we can also target this part of the life cycle with integrase inhibitors. Let's talk about nucleoside reverse transcriptase inhibitors. As you can tell from the name, they inhibit reverse transcriptase and they are nucleoside analogs. They're very hard to remember for me because they each sound a little bit differently, but I try to look for the bean, deen, seen sound, and then plus the two different ones. You gotta have those exceptions like abacavir and tenofovir. The mechanism is that they are nucleoside analogs. So just like how we talked about before, nucleoside analogs first go into the cell. If the cell is infected, what happens is that it gets activated by the drug. It gets activated by a kinase, and then the drug is then incorporated into the viral DNA. And it gets incorporated through the use of the reverse transcriptase. And once it gets incorporated, what happens is that it'll cause a termination. So you get a full-on termination of the DNA replication of the virus, and the virus can no longer replicate. It's used for HIV treatment, but it can also be used for hepatitis B treatment because hepatitis B actually does have reverse transcriptase. Most people don't know that. Now, zidovudine is going to be used for pregnancy. It's one of the first ones. It's also known as AZT, one of the first NRTIs to be discovered, and it is the only one that's safe for pregnancy, and is often used for if a pregnant female does not want to pass the HIV virus to her offspring. Talking about tenofovir, tenofovir is special because it's already pre-phosphorylated, and it's easy to remember because it has the pho in its name for phosphorus. Because it's pre-phosphorylated, it doesn't need a kinase to be activated. The big adverse effects for these drugs all vary, but the more common ones is going to be bone marrow suppression and lactic acidosis. Bone marrow suppression is pretty easy for me because if it gets incorporated into the virus's DNA, it can also get incorporated into the T cell or the macrophage's DNA and inhibit both of them as well. Here are the adverse effects for each of them separately. Abacavir is going to be associated with a HSR type 1 reaction or an allergic reaction if you have this HLA type. It's a B5701. Denosovir is important because it causes a pancreatitis. Stavudine can cause lipodystrophy. So I've got over here starvudine. It sounds like starve or stavudine, and it can cause this lipodystrophy over here, or just fat buildup, skinny arms, and then like just this fat buildup around your neck. Tenofovir is pre-activated, and but it does have a strange symptom in that it can cause Fanconi syndrome. You lose a lot of the nutrition through like amino acids from your kidneys when you have Fanconi syndrome. And you'll learn that more about that in renal. And then finally there is zidovudine. Zidovudine is pretty much low side effects. It does cause a lot of bone marrow suppression, but it is safe for pregnancy. All right, let's talk about non-nucleotide reverse transcriptase inhibitors. You can tell by the name that they are reverse transcriptase inhibitors and that they are not nucleotides. I showed you a picture of one over here, so you can see for yourself they are not nucleotide analogs. The three that you need to know about is nevirapine, efavirenz, and dilaviridine. The way I remember it is nevaefadilar. So as long as you can remember to nevaefadilar, you can remember the beginning of each of these. And all of these work by having VIR or VIR in their name. Most other antivirals have VIR at the end of their name. These are the only ones that have VIR in the middle. Their mechanism is that they bind onto reverse transcriptase of the HIV virus, but not at the active site. They actually bind onto the allosteric site, so it causes a non-competitive inhibition. The uses for it is going to be they're very useful because they are not nucleotides, so you don't get any bone marrow suppression. Our body doesn't get confused by it. It's only binding onto the reverse transcriptase, which our body doesn't really use. That's the HIV's protein. And another thing is that it does not need phosphorylation. Again, it's not a nucleotide. It doesn't need a phosphorylation to be incorporated or activated into the DNA. The important adverse effects is going to be the rash. That's probably the most common one, so they may ask that. But the more dangerous ones are the more high yield ones, like hepatotoxicity. And efavirenz causes a lot of vivid dreaming and seizures. It causes a lot of hyperactivity in your brain. They're all bad for pregnancy, and this is just from animal studies. We're not really 100% sure, but we never really want to take the risk. So you don't want to give this to a pregnant woman. You always want to give a pregnancy test before starting these non-nucleotide reverse transcriptase inhibitors. All right, let's talk about NRTIs and NNRTIs. There's a lot of differences between them, and this is a good chance for us to review a little basic pharmacology. Nucleotide analogs, like NRTIs, are going to be competitive inhibitors. They compete for the active site. It's important for you to know that. And by competitive inhibitors, they work by increasing the Km. Increasing the Km means reducing the affinity of the enzyme. Reducing the affinity means that occasionally the enzyme is not going to bind onto the substrate, but it's going to bind onto these drugs. So when it's not binding onto the substrate, you're losing the affinity. Over here, I'm showing you how a competitive inhibitor works on the active site. So the substrate can no longer bind, and the Km increases. The Km works by taking the V 50% and then seeing over here and then tracing it down, that being the Km. Going back over here, you'll see the Km has increased and its affinity has increased. So it takes a lot more substrate to get the same effect. The NNRTIs are going to be non-nucleotide analogs. They're going to bind onto an allosteric site, and they're going to work non-competitively. They don't care how much substrate you have. They're going to inhibit a certain number of enzymes, and they're just going to take them out of play. So pretty much it drops the Vmax by taking some of the enzymes out of play. And here's how it's going to work. It's going to bind onto the allosteric site, and it's going to change the formation of the active site so that it is no longer compatible with the substrate. The substrate can no longer fit there. As you can see, you get a reduction in your Vmax as compared to the enzyme without the non-competitive inhibitor. All right, let's talk about a protease inhibitor. Protease inhibitors are very easy to spot out because they all end in navir. And I just remember the mnemonic never tease a protease or never tease a protease. And the mechanism is pretty simple. It inhibits the aspartate protease, or just protease in general. As if you can remember, the HIV makes these long polypeptide chains over here, and then the protease then goes and it cuts it up into little pieces. That is used for the viral coat. If you have a protease inhibitor, you can get rid of the protease, or you can inhibit the protease, and you can prevent the virus from making a coat, i.e. you can prevent the virus from maturation. The uses for these proteases is going to be for mostly HIV, especially if they end in navir, or hepatitis C if they end in previr, which you can talk about a little bit more in the other lecture. The big adverse effects is pretty simple to memorize. Just think of a no protein, only carbs and fats, i.e. it causes hyperglycemia, high blood sugar, and lipodystrophy, or a lot of fat buildup under your skin. Over here I'm showing you the lipodystrophy that is often seen with protease inhibitors. It can also cause skinny arms and just fat buildup around the back of the neck. Some other issues that you can get is going to be GI intolerance. You're going to have a protease inhibitor and there's a lot of proteases in your GI, so you're inhibiting digestion of the protein. So that can cause a lot of problems in your GI. It can also cause kidney stones in the case of indinavir. And indinavir is the only one that really crystallizes and causes a lot of kidney stones. Something of note is that ritonavir is special because it actually inhibits the P450 enzymes. So if a patient is actually taking ritonavir, they get an inhibition of the P450. So that means that you need less drugs. You get less drugs that are metabolized, and that means that you can use a lower concentration, because if you're not metabolizing them as much, you can give them a smaller concentration and they'll stay in your blood a lot longer. And because you can use a lower concentration, you can have less adverse effects. That's why we really like ritonavir in cases where the patient is taking a lot of complicated drugs. You can often reduce the concentration and reduce the adverse effects. Something else you need to know about is that a lot of these HIV patients are also infected with TB because they're immunosuppressed. So when you give them rifampin, what that does is that it actually enhances the P450 system. And since you have an enhancement of the P450, you get an increase in metabolism. So a lot of these other ones lose the effect. So we often prefer rifabutin when people are taking protease inhibitors because it doesn't ramp up the P450 system and make these protease inhibitors useless. So let's talk about the integrase inhibitors. We've already talked about how reverse transcriptase can turn HIV's RNA into DNA. Now we need to find a way to inhibit the DNA from integrating into our own DNA. And that's where the integrase inhibitors come in. They're pretty easy to recognize because they all have a tegravir at the end of it. And tegravir kind of sounds like integrase, and then antivirals because it's a vir at the end. And its mechanism is exactly what I said before. It prevents integration. It prevents the integration of the viral genome into the host chromosome. The big adverse effect of integrase inhibitors is going to be rhabdomyolysis. For some reason, it causes a lot of muscle breakdown. I'm showing you this cup right here just to remind you what rhabdomyolysis does. You get a lot of breakdown in the muscles, so you get a lot of myoglobin inside of your blood, and that can all go to your kidneys, and that can cause you to have very quick kidney failure. And then you often see this very dark urine, like as if someone had just ran a marathon. So let's talk about fusion inhibitors. You only need to know two of them. First one being Maraviroc. Maraviroc, I think of it as the rock at the gate because it inhibits CCR5, which is found on macrophages with the initial infection of the HIV virus. If you can remember, the CCR5 binds onto the GP120, which I'm showing over here. This GP120 is going to bind onto the CCR5 and it's going to use it as a gateway to infect the macrophages, and then eventually it'll be used for the CD4 to infect the T lymphocytes. But what Maraviroc does is that it blocks the CCR5 receptor and it prevents the HIV from finding a gateway in. The second part of the HIV's envelope is going to be the P42, and that is going to be the fusion protein. It encourages fusion of the membranes. What we can use is that we can use Enfuvirtide. I can remember it because Fu stands for fusion, and Vir means antiviral, so it prevents the fusion of our membranes together. So that's just a very good way to remember that. And over here I've showed you, here's the GP41 over here, and what it's doing is it's encouraging the fusion of the membrane of the virus, which is found over here, with the fusion of our membrane over here, and this allows the virus to just sneak into our white blood cells. Treating HIV patients is one of the few times that an MS1 or an MS2 student is expected to learn clinical protocol of treatment. So I'm just going to go quickly over how we treat an HIV infection. Usually when you're treating them, you want to treat them at the time of diagnosis. You don't wait until they develop symptoms. You don't wait for anything. As soon as you're diagnosed with an HIV infection, you get treated. You don't want to wait until AIDS starts developing. And the treatment tends to be 2 NRTIs and 1 integrase inhibitors. This is also known as the HART treatment, the heart treatment. There's a new prophylactic treatment that is out, and so whenever you see a patient at risk, like a man who has sex with other men, being an at-risk population, you want to give them the PrEP, or the pre-exposure prophylaxis. And the pre-exposure prophylaxis is very similar to the heart treatment in that it has 2 NRTIs, but is different in that it does not include an integrase inhibitor. It has been found that it results in an 86% reduction, at least 86% reduction, if used 2 hours before sex and continued for 2 days after unprotected sex. Now, there are some prophylactic stuff that you have to give for an AIDS patient. Now, when I say an AIDS patient, it's someone who has HIV, but it's progressed to the point that their white blood cell count is being decreased. Something you need to know is that when they get below 200, they're at risk for pneumocystic pneumonia, pneumocystis jirovecii, so you have to give them Bactrim. If they get below 100, they're at risk of pneumocystis pneumonia and toxoplasmosis, so you have to also treat them with Bactrim. Finally, if they get less than 50, they are at risk of Mycobacterium ovum, and that is treated with azithromycin or a Z-Pak. Over here I've showed you how pneumocystis jirovecii is often represented on a test. It usually asks you a silver stain, and you know it's a silver stain as soon as you see all of that blue color. I just automatically know it's a silver stain. Toxoplasmosis gondii in an HIV patient will present these ring enhancement lesions, multiple ring enhancing lesions found in the brain. And Mycobacterium ovum is going to be these weird long nodules that you find over here. Alright, so how do you use this information? Like a lot of the other antimicrobials, you're going to focus mostly on the mechanism. Also, you want to focus on the adverse effects because there are a lot of unique adverse effects. The mechanism is important because if you can prove to them that you know the mechanism of the drug, you're also simultaneously proving to them in a way that you know the life cycle of the HIV virus. And the adverse effects are important because they're unique. They're just easy points for you to get in the test. For example, the lipodystrophy. As soon as you see lipodystrophy, you should automatically be thinking of a protease inhibitor or starvudine, which is an NRTI. Something else that you might want to look for is seizures. Efavirenz reduces the seizure threshold. So if they tell you that the patient suffers from seizures, you really don't want to add efavirenz on there because that'll just put them at a higher risk for developing seizures later on. Something you need to know about is that HIV patients are often on a lot of drugs. So please learn the important drug interactions that you would expect with HIV patients. A lot of HIV patients also have TB, so you should be able to know how the TB drugs are also interacting with the HIV drugs. For example, rifampin ramping up the P450 system, and that increases the metabolism of a lot of the drugs that we use to treat HIV, making it pretty much not effective. I've given you in a scenario right here where you're a third-year medical student. You're admitting a patient for pneumonia. The chest x-ray shows interstitial pneumonia, and the silver stain, they never really bring it up unless it's one specific disease. The silver stain showed a sputum showing weakly stained cysts. So you're getting a cystic pneumonia. What treatment regimen should the patient be started on? So obviously they're describing the pneumocystis jirovecii or pneumocystic pneumonia, and this is often seen as an AIDS-defining illness. If you've got this disease, you're pretty much guaranteed to also have AIDS. So of course we want to treat the pneumocystic pneumonia by giving them Bactrim, and this is going to be indefinitely because you want to treat for prophylaxis of future infections and also for toxoplasmosis. You probably want to get some labs out, just like a CD4 count. This CD4 count will help you determine if how low his white blood cells are, so you could possibly catch what other diseases you might need to prophylactically treat. Or you can get an HIV PCR to see how bad the infection of HIV is. Another thing you want to try to start treatment for is treat his HIV or AIDS, and that's going to be treated by the heart therapy, which is 2 NRTIs and 1 integrase inhibitor. A lot of the times when deciding which ones you're going to use, you want to focus on the drug interactions. Which ones are interacting? What drugs is he on right now? And which ones interact with them? You don't want too much of drug interactions. You want to look for past medical history. If he's an alcoholic, don't give him an NRTI that causes pancreatitis because he's already at high risk of pancreatitis. And also drug resistance of the HIV virus.